Hi, everybody. This is Dr. Arthur Zembowitz. I'm dialing in from Needham, Massachusetts, and I'm here with Dr. Marcus Bosenberg, who is in Vermont, even though he is a professor at Yale University. And we will be talking about genetic aberrations defining malignant melanoma. How are you doing, Marcus?
Doing great. Looking forward to this, Artur.
Yeah. So it's really a great pleasure to be here with Marcus. We go back a long time. We first met as the first year residents together at the Brigham and Women's Hospital in 1996. So close to 30 years ago. And one thing I can share with you is that from day one, I knew that Marcus is the brightest guy in the group. And but that was not enough. Another thing was that Marcus, I don't know if you remember that when as first year's residents, we were just learning how to cut, how to preview, how to manage our time. And we all just barely had enough time to sleep. Marcus, who had family at that time, he was able to go home and tile the bathroom on the weekend. And we were all just amazed. How is that possible? So this is someone who actually accomplished so much. I don't know, Marcus, do you need sleep or?
I guess I'm not sure, regrettably or non-regrettably, even less than when we were residents. So, not complaining. Coffee helps, but always lots of things to do.
Yes. Yeah, so Marcus went on to become a dermatopathologist and geneticist, and I couldn't think of a better person just to, talk about genetic aberrations defining melanoma, because Marcus practices Dermpath, but also has a very successful lab focused on melanoma, especially modeling melanomas in mice. That informed his perspective into being one of the very unique ones. And so I thought we'll talk about melanoma. Folks, the first thing before we proceed, I'd like you to scan this QR code. This will allow you to join the Mentimeter presentation. Another way to join actively is to go to chat, and I'm just dropping in chat a link to the Mentimeter presentation. When you click on this link, you will be able to also interact with us actively. Cell phone is a better way. It's a more efficient way, but if you have two screens, desktop is fine as well. Yeah, so scan the QR code, please. And this is, first, actually, I leave the QR code a little bit longer. Maybe I give you 20 seconds to scan the QR code, but you can also go to menti.com on your desktop or on your cell phone and use this code, and you will get to the presentation. So there are many ways to do that. So first, I have some warm-up questions for you. And the first one is, the current gold standard in diagnosis of malignant melanoma is, and what are your choices? I'm curious. I'll give you 10 more seconds because we have to practice our skills. And okay, so we're getting a picture. H&E got the most votes. Clinical pathological genetic correlations getting a lot of votes. So Marcus, what's your take on that question?
I love the responses with the 0% genetics. So, I was going in that direction anyway, but we'll talk a little bit more about how that can contribute. But I think between all three answers are really that are listed are kind of correct in that H&E is the basis for everything else, including the clinical pathologic genetic correlation. If a patient progresses and has metastatic disease, that's obviously something that's got to be figured in. And sometimes it doesn't make a whole lot of sense. And that's where the no gold standard, I think, can be viewed.
Yeah, I agree. And just another question for you as a warm-up. And again, I'm encouraging everybody to scan the QR code. If a melanocytic proliferation has a pathogenic TERT promoter mutation, it is a melanoma. Agree, disagree? It depends. I don't know. These are the options. And again, I'm going to give you only 10 seconds more. So Marcus, what's your take on that one?
I think, again, what a great audience. It depends is probably the best answer. We'll talk a little bit more about this during the hour, but I'd say that it's probably among the better genetic changes with respect to correlation to melanoma. That being said, is not every melanoma has a TERT promoter mutation, and that when one is present, it sometimes has been observed in melanoma in situ and things that aren't fully malignant. But that's relatively uncommon.
Mm-hmm. Okay, so let's start with a case. I have a case here. This is a 34-year-old female, right triceps lesion. And I'm going to show you H&E, and then we'll have some molecular studies, and I'll ask you for the diagnosis again. But first, I'd like you to make your diagnosis or your best shot at the diagnosis on the H&E alone, right? So here is this case for you. So we do have kind of a relatively symmetrical lesion. It's pink. Relatively young patient. Mostly dermal, but there's some junctional component. Just not a lot of pagetoid spread, or not at all. Epithelioid, pink cytoplasm, perhaps spitzoid, pleomorphic. Here's a nest, maybe a little bit more bland histology. And I go to the periphery here. Also, we have some kind of a dirty cytoplasm. Okay, what's your best shot on the H&E at this diagnosis, dear audience? So please go to the Mentimeter, and we'll discuss that case after I reveal to you the molecular features of this lesion. But yeah, that's an interesting case in a young person. Yeah. So let us take a look at the Mentimeter, how the voting is going. So atypical Spitz tumor, melanocytoma, got a lot of votes. And I give you 10 more seconds. Yeah, looks like. And now the next slide is going to be actually, I have another question for you. I forgot about that. Would you be able to predict which molecular abnormalities are possible likely in this lesion? And you can use a slider if you think one of those options is unlikely, you slide it to the left. If you think it's likely, you slide it to the right. Okay, I'll give you 20 seconds on this one. Those folks who participated in many Dermpedia events should have an advantage, because we discussed probably hundreds of lesions with known molecular abnormalities, but you can see that that's pretty much kind of predicted by the H&E diagnosis, right? The H&E diagnosis to some degree. There's a variation in different opinions. So here's the molecular diagnostics on this case. So this is NRAS mutated, missense mutation, CDKN28, frameshift mutation, PPRP, loss of function mutation, HLA. I skipped it quickly because actually I don't know how to interpret that at all, but it's being reported. And we have a bunch of other, potentially pathogenic mutations. And, I'm noticing here this one because that's familiar with me. That is cystainal leukotriene receptor 2 that is sometimes associated with epithelioid blue nevi, for instance, and mutational burden, 75 percentile. So now, and also there's, RNA expression panel essentially negative with the exception of overexpression of this particular gene, NY-ASO1. No kinase fusions identified on RNA-based NGS. So what is your final diagnosis after molecular? So I'll give you 20 seconds before. Okay, maybe I add some time to this. So what is your final diagnosis after these molecular features were revealed? So Marcus, what's your diagnosis?
I think I would probably come in with something like compound melanocytic neoplasm and have a very long note, and I'll explain why.
Okay.
In that this doesn't really, from my point of view, and you can see it's pretty hard to get a more perfect split between atypical Spitz tumor and conventional melanoma.
Mm-hmm.
One of the things I would want to know about this before making that diagnosis was mitotic rate or Ki67 positivity in terms of the lesion, because to me that would actually influence what I was thinking.
Mm-hmm.
If it has a low mitotic rate, I would probably be talking a little bit more. And so with the Spitz tumors, NRAS mutation isn't really perfect from a genetic point of view. It's more nevic than Spitz genetics. So that I think would inform a little bit what I'm thinking. If there is the absence of a TERT promoter mutation, presumably, I don't know that they test that, but I'm assuming that they do. That also does influence me a bit. One of the things that we'll talk about a little bit more that is worrying from my point of view is the tumor mutation burden of 7+ mutations per megabase is at the high end for a nevic lesion, but it's not really diagnostic in and of itself.
Mm-hmm.
So the balance of the genetics isn't really swaying me unequivocally to melanoma, but this is a lesion I would want to have excised in the patient, but I would predict that they probably will do pretty well, that they wouldn't have a bad outcome.
Because here I have also some actually in additional studies. This is a P16 that's lost, and I have frame that was focally present, but not much. And I think I have Ki67 maybe as well, or not.
Yeah,
Here's a
Velcro.
Ki67, and actually was FISH positive as well.
For
four panel,
okay.
standard fish. Yeah. So interesting lesion, right?
So the Ki-67 looked pretty low to me.
Mm-hmm.
The CDKN2A looked negative to me without genetic alterations, and we can talk a little bit more about that
Mm-hmm.
down the line as other things. The PRAME, I would guess, was less than the reported positivity rate of 75% of being positive, with the caveats with PRAME as well. So I just think this is a lesion that's really, really hard to tell, and I'm not sure that a right answer is fully obtainable without following this patient.
Right. Yeah. I think that's fair. For me, I mean, I ended up favoring malignant melanoma in this, and then, I reverted to my H&E assessment because, with that degree of, atypia and, I favored at the end that, it's best to manage this patient at least as likely melanoma, as we have no evidence of this being, in the Spitz category. It's more in a conventional category. But I think, those points about, I picked this case because I thought it's a very good example of how great this interpretations could be, right?
So I think also one of the attendees, Cynthia Heffron, also mentioned managing it as melanoma, which you just mentioned as well. And I completely agree with that.
Right.
So, I mean, I would say that based on excision, you want to make sure it's locally excised adequately. Whatever
Right.
you do to do that is what I would view as managing it as melanoma.
Right.
Now, if that included doing a sentinel lymph node biopsy, I don't favor that necessarily here. And the issue with that is in things that have been vaguely spitzoid in the past, we've had data that suggests that lymph node positivity does not correlate with a bad outcome or recurrence in borderline cases like this. So
Mm-hmm.
I don't have a problem if it was done, but I wouldn't necessarily be insistent on it.
Mm-hmm. Yeah, I would be more aggressive in my recommendations, perhaps, because I would consider that lesion, if there's no evidence of fusion, I would consider that melanoma. And again, H&E and kind of a historical maybe experience would make me think that way. But yeah, it's a really, I think great case. So let's move on. Let's learn something about genetics, Marcus. So
Right.
back to you. Take
just
over the screen if you can. If
perfectly.
not, I'll be pushing the slides.
I think you just have to, I don't have my arrows to advance things at this point, but
You do? Oh, you don't.
do
Okay,
not.
so I'll be advancing it.
Because I just have your screen of the live slide feed right now.
Oh, okay, okay. I'll see. Oh, here I see. Yeah, of course.
And
Here we
thanks.
go.
Now we're good. So also just very briefly, because there's some questions in the chat about Calvin saying it asked about mitotic rate or Ki-67 index that would make you more concerned for melanoma. I would say if you look hard enough in a nevus, you can find a mitosis. If you do enough levels, it will be there. But three, one or two mitoses, let's say, per millimeter squared or more. Ki-67 index was probably a little bit better here, like of about 5% or more, I think would be sort of the cutoffs that I'd be worried about. And then Rinku Susan Kurian asked about management of atypical Spitz and melanoma the same. I would say the excision margins wouldn't be that different, but the recommendations for sentinel lymph node biopsy would be for melanoma. For the present time, I'm not a huge fan of that, but then atypical Spitz, I wouldn't necessarily suggest that because it's discordant. So just kind of what the goals from my point of view is, and this is really wearing my dermatopathology hat today and trying to channel how all of you might be interpreting genetics or utilizing it in your own practices and how to move forward. And so just some background briefly for me is I've also you've been the co-leader of our cancer genetics program, not just in melanoma, but otherwise at Yale Cancer Center for about 8 years. Now I've moved more towards cancer immunology, and that's kind of the area I work on. But then also have been the leader of our spore and skin cancer grant, which has been one of the places where a lot of the genetics for melanoma were kind of worked out, along with the data I'll show in a little bit. So I'd like to kind of give you guys a little bit of a background on melanoma genetics, and then maybe some perspective about what role genetics might play. Not advancing for me, Artur, so I'll just have you advance. So we had a paper out of Yale with my colleague Ruth Halaban, and there was another paper from Harvard around 2012. But in 2015, sort of the landmark study for the genetics of melanoma was published in the journal Cell, and this is kind of the overview of that. And Alex Lazar and Richard Scollier were the pathologists that kind of reviewed cases, and this was notable for its rigor in making sure samples were what they were supposed to be and so forth, and kind of established the basic genetics that we see in melanoma. And that's not really been, there's been additions to that since then, but not substantially different additions.